Bismillahirrahmanirrahim. Thank you very much, Dr. Mudassir, and thank you very much for all my teachers who are sitting here, who have spared their time to come and join this event. Today, my topic is new armaments in cardiac surgery, like minimal invasive cardiac surgery, robotics, and hybrid procedures. So, cardiac surgery is entering in a new era powered by innovation. Like Dr. Thoracic said, it is very important. It is entering from minimal invasive endoscopic and robotics to hybrid operating suites. And these innovations are transforming how we operate and how patients recover. These new armaments are redefining precision, reducing invasiveness, and setting a new standard safety and outcomes in cardiac care. So what is minimal invasive cardiac surgery? Almost everyone knows here, but for those who are new to it, minimal invasive cardiac surgery is a type of heart surgery performed through small incisions, often between ribs, instead of sternotomy or cutting breastbone, and it is assisted by endoscopic and robot-assisted surgical systems like Da Vinci system. Now, hybrid cardiac surgery is a combination of open heart surgery and less invasive catheter-based interventions done simultaneously in specially designed operating suites where cardiac surgeons perform surgical procedures and cardiologists or intervention cardiologists perform the catheter-based procedures, like cardiac surgeon will anastomose lima to LAD, and surgeon will and interventions will do the angioplasty for rest of the vessel. Now, why it is important? Because minimal invasive cardiac surgery, there is reduced trauma, shorter hospital stay, and faster recovery, lower wound complications, and improved cosmesis. It facilitates enhanced recovery. Now, these are some levels of minimally invasive cardiac surgery. Level 1 is 10 to 15 centimeter. It is a direct visualization minimal invasive cardiac surgery. Most of the Pakistan's minimal invasive cardiac surgery comes in this level. Most of us are doing this level of cardiac surgery. Level 2 is 4 to 6 centimeters, direct visualization and video assistance. There are few procedures done in Pakistan which come in this category. Level 3 and 4 are still not available in Pakistan, and these are done worldwide. Level 4 is 1 to 5 centimeter, 1.5 to 4 centimeter, and incision is there, and it is assisted with endoscope and sometimes with robot as well. And fourth level, which is the one in which incision is 1.5 centimeter only, and it comprises of totally endoscopic and robotic telemanipulation. Now, you can see the graph from 1950 to 2030. You can see the open heart surgery or conventional surgery graph has increased till 2010, but it is declining now till 2030. And minimally invasive cardiac surgery, which started in 1990, it is increasing, and still it is increasing till 2030. But transcatheter technologies are increasing enormously. There is a significant increase. This chart, this is the chart is taken from European Heart Journal 2015, older, but it shows the procedure mitral valve repair. Initially in 2009, it was done through sternotomy, and a few cases were done minimally invasive. But till the end of 2014, Now the majority, more cases are done through minimal invasive and less cases are done through stenotomy. Now understanding the approaches of minimal invasive cardiac surgery, these are the catheter-based like TAVI procedures done through aortic or apical, femoral, axillary, or some percutaneous stenting done through radial. But we are concerned here about the surgical procedures. One is stenotomy, is still the most common approach for all cardiac surgeries worldwide. But now the trend is changing. In stenotomy, now some surgeons have come to making it less invasive and coming on the partial stenotomy, like lower stenotomy for mitral valve repair or replacement or some cabbage procedures, and some are doing upper partial stenotomy for aortic valve. Stenotomy free procedures like mini thoracotomy, I told you the levels. Direct BN mini thoracotomies are done, and direct BN procedures are done under direct BN in like right anterior lateral mini thoracotomy or left anterior lateral mini thoracotomy for mitral valve or aortic valve replacement or repair or cabbage. And assistance from video or endoscope is taken, and other is the fully endoscopic, maybe manual without robot, surgeon himself operate, or robotic. This diagram shows the incision sites. Like I told you, this partial stenotomy for aortic valve replacement, and other is the right anterior lateral thoracotomy. This is done in second intercostal space for aortic valve replacement. If we go in same side, we go in third intercostal space, same anterior lateral thoracotomy, we can do aortic valve replacement and mitral valve or tricuspid valve repair or replacement. This site is for, this is the fourth intercostal space, and it is a bit lateral, and it allows us to perform surgery on mitral and tricuspid or ASD. On left side, this incision is for minimal invasive cabbages, which need more than 1 grafts, and this is in fifth intercostal space, and we can do mid-cap direct. We harvest left ventral memory artery and anastomose with LAD. So what is direct VN cardiac surgery? Direct VN minimal invasive cardiac surgery is surgical technique where we do mini thoracotomies, and surgeon looks directly into the operating area, and there is no use of camera. And cardiopulmonary support is taken from taken by peripheral or central cannulation. Majority of the procedures still in Pakistan and worldwide are done through this direct VN cardiac surgery, and it is the level 1 cardiac surgery, or we can say it is some level 2. And most of the procedure, all procedures can be done through direct VN, like cabbage, aortic valve replacement, mitral valve replacement, tricuspid, DVR, ASD, everything can be done through direct VN. Again, this diagram shows the incision sites, I already told. So this is the position of patient in operation theater for minimal invasive cardiac surgery. You can see the double lumen tube. Most of the minimal invasive cardiac surgeries, double lumen tube is used, but it's not necessary. Single lumen tube also can be used. This is a intrajugular venous cannula for drainage of superior vena cava. This is the site for clamp. If we don't have flexi clamp, we can put chitwood clamp from axillary area. And this is the thoracotomy site for mitral or tricuspid or ASD. Now this is a 5 centimeter incision, and this was 110 kg patient, and this is right anterolateral thoracotomy for aortic valve replacement. This was done in direct vision. So level 2 and 3, endoscopic cardiac surgery. Endoscopic cardiac surgery is minimal invasive cardiac surgery where endoscope is used, and nowadays 3D endoscope is nowadays. Am I audible? Nowadays 3D endoscope is available, which gives a very good a view of the operating area and precise measurements, and which is useful in especially in repairs. You can see surgeon is operating, and he is looking at the screen for operative field. There is a small hole about 3 centimeters for which is like a working hole, which is for passing instruments or valve or clamps or cannulas. Robotic heart surgery is an operation a surgeon does by controlling robotic arms that work through small incisions, and it is popular because of less pain, less time in hospital, and there are initially there were multi-port robots which had 4 ports and 3 ports were used, but nowadays single or uniport robots are available in world. So this diagram shows all the procedures which can be done through robotic surgery, like beating heart, single vessel or multi-vessel, or arrested heart, single vessel or multi-vessel cabbage, total arterial off pump and on pump. Most of the coronary artery procedures are done robotically. These are multi-port robotic system in which different ports are placed for the arms of robot. You can see a Da Vinci system where surgeon is sitting remotely and assistant is on the patient side or surgical side, and main surgeon is operating by telemanipulation by a robot system. Da Vinci robot system is nowadays famous cardiac surgery. These are some 4 robotic arm enabled solo surgery, and in these robotic arms there is a 7 degree of freedom and 90 degree of articulation, and this improves the motion and reduces the tremor, stabilizes surgery, and there is a 3D high resolution 3D cameras are used, which increase the view and quality of the. Now, endorist is like arm of a robot, which has very fine movements, and these are having very wide ranges of movements available. And you can see its angulations and articulations are very helpful. Here you can see the patient sites for the robot. This is the camera port. These are the working ports. Take the picture taken from a Da Vinci system, where in center there is camera port, and one is cautery port and Gresper port or working port, and most probably cabbage is done from left side of it. So hybrid surgery is a procedure that combines both conventional and open heart surgery with less invasive and catheter-based interventions performed in same sessions. And these are performed in specially designed operating suits, as I already told, that like hybrid cabbage, surgeon will anastomose lima to LAD, and intervention cardiologist will open the other rest of the arteries with PCR. This is picture from a hybrid suit where surgeon is harvesting or anastomosing lima, and intervention cardiologist is doing his intervention. Now, what are the tools for minimal invasive cardiac surgery? There are certain tools which help in minimal invasive cardiac surgery, like specialized retractors, small retractors, atrial lifts, and many other inventories required for minimal invasive cardiac surgery, and long instruments, long needle holders, long graspers, long diathermy tapes. And some are, and helpful instruments are Carnot devices. These are not necessary, but these are really helpful. Carnot devices and RAM devices. Carnot device is a device which can, which allows surgeon to tie a knot without going or without reaching the knotting place area from outside patient. This is a RAM device. This is a new innovation by Life Sciences, and it is a device. It takes the, you just need to place it over the annulus, and you have to press it. It takes the sutures, because in totally endoscopic or in endoscopic surgeries, it is difficult for surgeon to take the sutures from the annulus area. So this RAM device helps to take the stitches instead of we going in by a needle holder. This long RAM device goes in. It has two needles already installed, two needles, and you just need press, and this suture will come out. Now these are different meta-analysis, and in these meta-analysis, you can see there is no difference in mortality between minimal invasive cardiac surgery and conventional cardiac surgery, but there is better quality of life, lower hospital stay, and equal transfusion rates. But the minimal invasive cardiac surgery, there was longer operative, bypass, and cross-clamp time, but the ICU and hospital time was less. So minimal invasive cardiac surgery in Pakistan, everyone knows that we are still at back foot, but since 2015, many centers took initiative and started minimal invasive cardiac surgery. We are still at level 1 or 2 in minimal invasive cardiac surgery. So reasons are why we are on back foot, because it is lack of fundings. Like in private sectors, patients are non-affordable. In government sectors, there are not sufficient funds for providing the tools or instruments for minimal invasive cardiac surgery. And there is no any specialized training center for minimal invasive cardiac surgery. And other reason is the nature or type of the disease. We have very diffuse coronary artery diseases, and we have very bad valves present for clinic. This is some data from Tabba Institute. Since 2018 to 2024, we can see the ASD repairs were 73 through the minimal invasive approach and 45 through mediastenotomy. Likewise, comparable number of AVR were also done minimally. And this is a graph which shows the number of minimal invasive cardiac surgeries comparison to anatomy. Now, how can we improve minimal invasive cardiac surgery in Pakistan? Simply improving the level of minimal invasive cardiac surgery to level 2 or 3 now should be our next goal. And encouraging the industry, local industry, for manufacturing the quality tools for minimal invasive cardiac surgery, because these are very expensive tools which are difficult to get in countries like Pakistan. And establishing specialized training centers and labs for trainees and junior surgeons for the practice. As you can see, a lab for practicing the endoscopic cardiac surgery, and most important is collaborating with the other centers of the world which have high volume, and we should collaborate with them and learn from them. So conclusion, the tools may be new, but the goal remains the same: saving hearts and improving lives. The future isn't coming, it's already in our hands. Thank you very much.